This is the Congenital Heart Academy. Again, we're very happy to have sorry, I have a problem with the internet here. I hope you hear me.
Yes,
You need
but
to turn your volume down.
So, in behalf of
we cannot hear you. Rima.
okay, we'll try and do something. Something happened. So I'm sorry for that.
You have to
On behalf of the Congenital Heart Academy, I'd like to invite all the speakers on board today. We have a beautiful group from Germany, and in the Congenital Heart Academy fetal webinars, we always try to get a variety of different schools, different practice, and very grateful to Dr. Sasha Agati, who's like the father of this project, and Dr. Silverman, who's always on board, and Dr. Grace also on board. So today we have three eminent speakers, one pediatric cardiology, and two obstetric consultants or in prenatal medicine. So I'd like to introduce the very, very famous Dr. Ravi Shawi, professor of obstetrics and gynecology from Germany. And he's going to talk about, to us as cardiologists, as prenatologists, as obstetricians, as fetal maternal specialists, he's going to talk to us about first trimester scan. And I think we should really enjoy listening. And at the end, we can have a few questions. Dr. Shawi, you're most welcome.
Thank you. I need to, my video. You cannot see me, but you can hear me, I guess.
Yes, you have to open the video.
I'm trying, but it tells me that the host.
Share screen, share screen, share screen.
Okay.
Yeah, beautiful.
Okay, we got you. Yes. Okay, yes. Perfect.
Even if you don't see me, because my video cannot be started, my face, but it's
okay. Fine.
Now you can see me. Great. So thank you, Rima, and thank you, Norman and Sasha, for your kind words, invitation. And I was asked to speak on the first semester heart. So this is a field where many pioneers in the world have started in the early 90s, and today is not the question if we can do it, but rather on how it can be done. When perinatologists discuss on the first semester, they are discussing about nuclear translucency and the screening for trisomy 21 and aneuploidies, but in the meantime, we have a very good approach to see many organs. But I think the heart is still one of the most important ones to consider, and only for your understanding, if we take an incidence for complex cardiac malformation of 3 out of 1,000, which is 1 out of 300 cases in the general population, and early gestation, the rate is even higher. This is actually a risk a woman has for trisomy 21 when she's 35 years old and older, so and younger. So in other words, every woman younger than 35 years has a higher risk of a cardiac problem than of a trisomy 21. This is why people working on fetal cardiology try to focus on the fetal heart early gestation instead of saying, look at the neck and Down syndrome and so on. But we have to train the people. And we know from the beginning that we have a very good detection rate in second trimester, even until very tiny diseases. And there is a big potential for first semester. So the problem we may see is that we know in second trimester we have well-defined planes for fetal echo, we have guidelines, we have color Doppler, we have indications. Color Doppler is used, some of them additional, some of them optional. For first semester, we don't really have planes, so we are using the same planes. We don't have true guidelines. They are part of general guidelines of anatomy. Color Doppler should be mandatory because without color Doppler, you may not see anything. And indications, there is no true well-defined indications. We invent sometimes some of these. And when I'm asked to speak on these conditions, I say always there are two approaches. There is the ideal setting and the practical setting. And I'm personally more a practical person because ideally, we should pretend that every sonographer is an expert. Every 12 weeks heart should be scanned with the accuracy of 22 weeks heart, which should not be really the case. Every 12 weeks heart is scanned transvaginally, ideally, yes, but you can do it abdominally very well. And we should always keep in mind the time dedicated to scan versus the results. Because if you look at it from practical point of view, if you are looking for 5 to 10 out of 1,000 pregnancy, you mean if you want to scan vaginally each patient, you will have to scan 990 patients for nothing, and only for 10 cases where you will find the details. So it should be something, in my opinion, should be something simple and efficient. And the more simple we do it, the more efficient, or let's say the uptake will be easily accepted by many doctors and sonographers. And we should also keep in mind the high risk versus low risk. So in my opinion, the high risk patient should be scanned in a comprehensive way. That means if you have a thickened nuclear translucency, or you have a previous history, or you see additional signs. But if you have a screening patient, you should scan it simply with the simplest way. And keep in mind that all patients has to be rescanned later on in the second trimester. So we will, it is a kind of second net where you can discover these things. There has been for years, with the introduction of the nuclear translucency, two different approaches. There is the approach suggested by the different fetal medicine societies, especially the one in London around Nicolaides. There are 3-4 approaches. You can find the risk for a heart. So if you have thickened nuclear translucency, or if you have discovered tricuspid regurgitation or a reversal flow in ductus venosus, and as we described recently, in shifted cardiac axis, then you have a high risk for have a cardiac anomaly. And what we say here, we try to teach people that please get 4 simple views: one on the upper abdomen, moving to the 4th chamber view on grayscale to see the septum and the 2 chambers, add the color to see the 4th chamber view, and add the color to see the 3-vessel trachea view. And if you have let's say a good lying fetus, is a question of less than 1 minute where you have this information, and then you can reschedule the patient for a second trimester scan. So here, first of all, the first part shows that there are several publications showing the thickened the nuclear translucency, the higher is the risk of presence of a cardiac anomaly with or and without underlying aneuploidy. So this is why the thickened nuclear translucency could be due to a cardiac anomaly in general, in combination with the tricuspid insufficiency. Or if you see some of these hints, like tricuspid regurgitation or ductus venosus, this increases the hint. And we are published with the group of Virginia, Norfolk, Abu Hamad, and Sinkovskaya in the Greek journal, a paper showing that the cardiac axis is shifted in 75% of cardiac anomalies. So it can be used as an additional hint. All these are, let's say, more for people who are not really scanning the heart, but looking roughly to the region of the heart, so they can calculate and measure the cardiac axis and see it as an indication and refer to a specialist for fetal cardiology. Rima was asking the German afternoon, and this is why I have to add the German guidelines for first trimester, which is the DEGUM, which is the German Society of Ultrasound. There we have decided that standard view should be for the heart, the position, contour, and the 4th chamber view. An optional parameter, which means this is what we encourage people to use, are the outflow tract in color and the 3-vessel trachea view, as I was telling you before. So And the message I want to give to many people is, if you want to be good in first semester, be first good in second trimester and try to translate into miniaturized heart. And the equipment and technique are very important. People tell me, oh, you know, you have a very good machine, but the essential is your knowledge. If the knowledge is even much more important than what you see, because you should deduce what you see on second trimester, what could be in the first semester. So this is why I think this important. The knowledge is sometimes even more important than the views you will see, and I'll show you some examples. So the main message is, as usual, keep it simple and don't make it complicated. Don't make it such a big thing that people will be, let's say, not discouraged to do the first semester scan. So let's move now to the typical planes. In my opinion, the practical view, the situs, mainly focusing on the stomach, on the position of the stomach rather than on the IVC and aorta, which are difficult to see on the normal conditions, and to get the 4-chamber view in grayscale to demonstrate the septum, then moving to get the 4-chamber view in color and the 3-vessel trachea view. I do not encourage on a routine setting to look at the 5-chamber view as LVOT or a short axis view, because if you tell people, you know, it is so simple, but you need at the end 10 different planes, people will not do it. You will see anyway that at the end of the day, the 5-chamber view abnormalities are also abnormal in the 3-vessel and trachea view. People discuss often the issue of should we do it all transvaginally and transabdominally? Of course, by far, the transvaginal view is by far better. It is for cardiologists, it's like the difference between scanning transthoracic or transesophageal. The endoscopic approach is, of course, better, but the question is, for a screening setting, its examination can be done within 15 minutes. If you have the standard good images, why should you move? And I do personally transvaginal view if I have a high-risk patient, if there is limited visualization, like in this case, you see here, the heart is so deep and I cannot approach the heart, and the cervix is closer to the heart, so I scan vaginally. Or if the length, the crown rump length, the fetal size is small, so below 12 weeks is of course better transvaginally. And I show you this is an example I recorded a few days ago on a patient, showing you if, look how many seconds, something like 10 seconds, the fetus lying in a good position on its back. You hit the button here and you see the 4-chamber view, you go to the 3 vessels, you add the color, showing the filling of the chambers, moving the 3-vessel view, and that's it. And this plane I have ruled out, the hypoplastic left heart, right heart, large AV septal defect, overriding of the aorta, common arterial trunk, right aortic arch, and all anomalies I will show you. And you've seen it is a question of really few seconds, provided you have a good preset and you have good color setting and you have a fetus in good positions, good scanning conditions. This is why I ask you, please, now don't ask me later on if I have any concern of using color. I do not have any concern of using color 0, because I'm using the color time very, very short, the much I need. And I think the efficacy is by far more important, and it's way more than any concern of energy we are using. The energy is still low because you see here is MI and TI are lower than 1.0. So, and you see this is a routine. I scan here, and what I see in this image is the stomach on one side, the heart on the other side. And you see, it was the evening here at it was 4:45. I asked the lady to go out, and then I scan her vaginally later on at 6 o'clock when I finish my day to scan accurately to see that here what is the underlying cardiac reason. So in screening, I discovered the discrepant positions, and then I say it could be isomerism or could be an isolated dextrocardia, and then I go for a targeted fetal echo. And this is how we work daily. Now, many people are afraid of doing, on one hand, fetal echo, but on the other hand, also first semester. I tell them, I'm not asking you from the first time to get the final diagnosis. I need only you to tell me if there is any abnormality, and there are enough specialists in your neighborhood who are able to make a diagnosis, and you can even postpone the examination for a later occasion to get the final diagnosis. So don't be discouraged. Try to get the information. The heart is normal or it is suspicious or abnormal. Let us see some images of the 4-chamber view. So the 4-chamber view here is important because it can detect a series of abnormalities, not all. And I did not put in my talk the anomalies not yet detectable, like cardiomyopathy or tumors and small VSTs, but roughly the thing we can see. But what I want to highlight here at this stage is that some of these anomalies, the one seen here, may appear, especially when you are using color Doppler, as a single ventricle. So the diagnosis of single ventricle is very, very common. And this is here what people show me. They show me a picture where they see one stripe of color and they say, I assume a single ventricle. And I want to warn you, it is rarely the true single ventricle. It can be a single ventricle physiology. But at the end of the day, be careful in counseling patients on this condition because we need more information. And in our book here on first semester abnormalities, we wrote that interestingly, the classic univentricular heart is really rarely present. Given the small size in first semester, hypoplastic left heart, tricuspid atresia, mitral atresia, large AV septal defect, and severe coarctation may be present as a single ventricle. I'll show you some examples. So, and this is here one of the list. And also, I did not put it here. It can be also a false positive due to a lot of color mimicking kind of one chamber if you don't know how to make the proper preset. So you see here at 12 weeks gestation appears like one chamber with a regurgitation. A few days later, when the lady came for a placental biopsy, chorion sampling, you could see on grayscale, it is a typical AV septal defect with an echogenic focus in transmit 21. But here with this preset, it appeared as one stripe. So this is why it is not a single ventricle, it's a large AV defect. Or look at this. This is, for example, in hypoplastic left heart syndrome, it is an absent left ventricle. You see one chamber. By looking to the great vessels, you see the reverse flow in the aorta and the dilated pulmonary arteries. Those typical picture of a severe hypoplastic left heart with an absent left chamber. And this is not a true single ventricle. It is a univentricular heart and hypoplastic left heart. The same here in tricuspid atresia, you see abdominal view and transvaginal view, how the quality changes when you scan vaginally. Then you see the flow going around the left side and then across the small VST into the small right ventricle. I want to share with you really an eye-opener case for me, because I'm sure many of you, even me, could have done the typical mistake, because you are what is called, you are primed by what you want to see. So the first child I did discovered 2 years ago had a hypoplastic left heart, unfortunately died after operation. And she came for 12 weeks gestation. And this is what I saw. I hope not to see a hypoplastic left heart, but I saw what looks like a hypoplastic left heart syndrome. We see one chamber here, and this was a nice era patient. The husband said, not again, I will terminate pregnancy. He said, please give me a chance to have a look at the baby. And the woman said, I will not. Said that we do not discuss now this issue, but want to together to see what is the correct diagnosis. So give me a chance to scan vaginally. And vaginally appeared similar. So we see the one chamber here and discussing and putting the color. And I was surprised that in one of the planes here, as you see, a second chamber appeared. And I assumed first it can be only a hypoplastic left heart syndrome because of the previous history, but probably it's a history of familial, let's see, bicuspid aortic valve probably, and one case may have been hypoplastic, the other one can be severe coarctation. And you see here again, we are 12 weeks plus 5. You see here the narrow but well-filling left ventricle. I told him, no, the chances of coarctation are excellent. I cannot demonstrate any reverse flow in the aorta. So let us give a chance to have a look. And then I show you now here at 22 weeks, I scanned her several times. And at 22 weeks, we have a good filling of the left chamber and we have a typical picture of coarctation. I don't want how many of my colleagues, peers, or people doing scan, they have stopped the abdominal saying it looks like a recurrence of hypoplastic left heart, and the lady may have stopped pregnancy. And believe me, there is no pathologist who is really able to tell you, oh, it's not true what you have done. So this is why my recommendation is when you see anything in early gestation, you can make your diagnosis, but give the chance to have a look, a second look, 1, 2, 3 weeks later to make to the final diagnosis. And patients are very willing on getting this, unless there are several abnormalities on the fetus, and this is an additional one. Look at this case here. It's also for me something crazy because the patient was referred by an expert on fetal, on fetal anomalies because the great vessels were not appearing very well. And what you see here is the filling of two separate chambers, but this is a false negative because this is a true single ventricle. Why? Look at vaginally, the picture vaginally. What you see here is a double inlet ventricle with one chamber. But if you add the color, you see the two stripes, and your brain is prepared to see if you have two stripes, it means you should have two chambers. This is why I tell people, do not rely only on color. Please, I want you to see the septum in between the ventricles. If you look at back here, you see here the single chamber, but you see here the white dot I showed you from the abdomen. So the detection was rather on the great vessel because they are in general, they have an abnormal origin in the double inlet ventricle. But I want to tell you that the true single ventricle, the double inlet ventricle, may even appear as a normal heart in the fourth chamber view in gestation. So this is something very, very peculiar that some two chamber may appear one chamber, some one chamber may appear like two chambers. And this is why I give a chance to have a second look at. So this is why my suggestion for this part, because this is the most common referral in gestation to see a single ventricle. So check on 2D and color Doppler, check transvaginally, look at the great vessels and use your knowledge from second trimester to see if the great vessels, what they look like, and then counsel the patient after having performed a scan a few weeks later. And here are some examples on the fourth chamber view, the normal fourth chamber view, the hypoplastic left heart, AV septal defect, double inlet, coarctation, pulmonary atresia, and even dextrocardia. So some of the examples. Now let's move rapidly to the great vessels. And in the great vessels here, as I told you, you can get the view here. The 5-chamber view may be also seen, but in general, I will mainly focus on the 3-vessel and trachea view, where you see the two vessels here as a V sign pointing to the left, and you can even recognize the trachea on the right side of them. And in this plane, we can see any abnormality where the aorta may be large, like in common trunk, or you see only one vessel because the other one is hiding, like in malposed vessels, or you may have a reverse flow in either the artery or the aorta, and other signs like interrupted vessels. You rarely are able to see a left superior vena cava because of its tiny size, unless you have some tricks. Now you see here an example of a normal looking for chamber view. The 3-vessel view appears with a narrow pulmonary artery where it is entering by the side of the aorta, so an abnormal 3-vessel view, and the reason is the tetralogy of Fallot. And you see here this fetus at 13 weeks, the nasal bone is normal, the neck is normal, so there is no hints on the nuchal, but looking to the heart, I'm using in these cases when I have a suspicion, a linear probe, and you see here the overriding of the aorta, and then this is in addition a right aortic arc. When you see the trachea here and the aorta scores is on the right side of the trachea, the 3-vessel trachea view. One of the very rare conditions you see only in first trimester are these ones, the typical dysplastic valves in trisomy 18 or 13. What we see here is a through and through flow over the aorta and the pulmonary artery. Some call it absent valves, but these are dysplastic valves. And typically the fetus has, as you see here, large hydrops, and they die between 12 weeks and 15 weeks. So this is condition typically found in early gestation where you have, let's say, only bidirectional flow. And this is almost typical for these trisomies. Now let's see here the typical sign we know of transposition in the great arteries at 22 weeks. We see instead of the V sign, instead of the 3-vessel view, a single straight vessel, a little bit bent. And this is the same you can see at 13 weeks. So if you have this view in the upper thorax, instead of having the V sign, rotate the probe in order to get almost a longitudinal view, and you see the parallel course of the vessels. This looks typical for transposition, but it's typical for malposition of the vessels. So also in double outlet right ventricle, if you have, let's say, a normal aortic arc and not, let's say, hypoplastic, you can see it as well. So it is more for malposed vessels that one is under the other, and you can get a sagittal view to see it. You see here transposition screening, so you see the four-chamber view, the parallel course of the vessels, and then the oblique view to get the parallel course of the vessels. So on the other hand, I have no problem if we miss at first semester the transposition. First of all, it is almost never associated with any chromosomal anomalies. Second, it has excellent prognosis. So even if you detect it in second trimester, it will not change management at all. Now, I showed you the case with the right aortic arc in combination with the tetralogy, but it can be also right aortic arc isolated. And if you know how to adjust the color, you can easily recognize the typical U sign, the letter U, where you see the trachea is between. You remember the normal scan I showed you with the V sign. But at this stage, I'm not always confident in telling if it's an only right arc with left ductus or if it's double arc. So this is why this condition will have a check later on and pregnancy. And this is here a case at 13 weeks, an accidental finding of a double aortic arc, where you see here the bifurcation of the aorta in front of the trachea. So we can distinguish them, but in case we see only a right arc, you can refer it later on to have a second view later on gestation, which does not change prognosis. But only that these children need operation after birth, and the one with the right arc rather no. You see here the trachea interrupted between the double arc side. And again here for the three vessel trachea view, the reversal flow in the hypoplastic left heart, the interrupted aortic arc, the right arc with tetralogy of Fallot, the double arc, and the single vessel in transposition, and here the aberrant subclavian in some of this condition. I see in this meeting today, we have two sessions after me on heterotaxy and on lung vein anomalies. And I want to show that we are also able to recognize such condition early gestation. You see here the typical sign of left isomerism with the azygos and aorta side by side. This was detected because the fetus had the heart on the other side, or more easily in this fetus because it was a bradycardia, and there is no other reason for bradycardia early gestation than isomerism. And you see the two vessels here side by side. And last but not least, if you see a fetus with the stomach on the or the heart on the other side and having complex cardiac malformation, think also on the presence of right isomerism. And right isomerism, you may also discover an abnormal lung vein drainage. And you see here at 13 weeks, in this fetus, you see behind the heart, the confluent vein, and you see on color Doppler that this vein is not entering the atrium at all. So it is, I'm not really confident to tell you I will have discovered this condition on a routine normal fetus, but if you are primed because the fetus has a sign of isomerism because of the position of the abdominal and thoracic organs, then you can discover or you can seek for this condition. I assumed in the past it's not to be discovered, but I've seen in the meantime several cases, so it can be also done. I come now to the end. I want to show you two studies. One published in the Journal of Ultrasound Medicine by a group from Poland, Dr. Witczek, showing that the shape of the four-chamber view and the shape of the three-vessel trachea view can be of big help, and showing what I was telling you at the beginning, that if you take a four-chamber view and you add the three-vessel trachea view, you may have 90% detection rate of the detectable anomalies in the first semester. So if you take only the nuchal, is only 30%. And last but not least, there is now a paper which is going to be published soon in, I hope, in the White Journal, by taking meta-analysis written by Karim and Jihan Karim and Aris Papargeorgiou, showing the different studies, and the main message under the line is that if you use the color Doppler and use the outflow tract view, you increase the detection rate from 30 to 80%, similar to the study I showed before. So I come to the conclusion, and again, I'm confident that simple signs like nuchal measurement, tricuspid regurg, ductus venosus, and cardiac angle may be of importance, but give also a chance to simple approach combining the upper abdomen, the four-chamber view in grayscale, the four-chamber view in color, and the three-vessel trachea view. And remember, the case I showed you shows you that this picture would have not been seen in a single heart, but this, he cannot rule out that there is an absence of the septum. So please combine these two. And if you want to read more, a small advertisement at the end, refer to our book on first semester, but also we have just now finished the book on the new edition, the 4th edition on our practical guide. And I hope you will find some of the information there. And I thank you for your attention. And if you have any questions, I'm glad to answer them.
Thank you very much, Prof. Shawi. Beautiful talk as usual. And a few comments because you're so good in scanning. Now, to make it for the people who would like to be able to scan the first trimester, what you said is that transabdominal could be okay and is okay provided that the habitus of the mother is okay. Yeah. So what are the probes that you're using? And the setting is very important. I think the beautiful advice you said that be good in second trimester before you try the first trimester. But let's say, what about the probe, the frequency, and the settings that you like to use in the first trimester? I could see that most of the cases you've done were 13 weeks plus. So what about the 12 weeks as well?
Yeah, in general, I try to book my patients, let's say 12 plus 5 to 13 plus 2. So, and at this stage, you are quite able to see if you have, let's say, acceptable scanning conditions, the filling of the 2 chambers and the 3 vessel view. These 2 images are almost always feasible at this stage. So, and I use, let's say, a regular high resolution probe. We are at 7 to 8 megahertz, even 9 megahertz. I have a linear probe I'm using for special cases. It is conditions where I'm not really sure that I can get it vaginally. But of course, if I have any suspicion, I will switch vaginally. So if you are, let's say, pediatric cardiologist and you cannot do because for several reasons, so why not to scan the patients 2 weeks later? So 14 weeks, 15 weeks are also fine. You know, the issue is, do I really need to know all things at 12 weeks? Of course, it's for me a challenge. I want to show off that I can see the lung veins at 13 weeks, 12 weeks. But, you know, but if there is any suspicion, you can say, you know, I'm not sure, come back in 2 weeks. Because the alternative would have been come back in 22 weeks scan. And there is a time between these two.
So you're using a linear, not a curvilinear in the early.
I'm using curvilinear, and for targeted, I use the linear.
And your curvilinear is what frequency that you're using?
Let's say 7 megahertz. So the highest I can get for abdominal scan. So
there's a 9 as well. I mean, from some companies.
Yeah, but they say 9, but in general, there's a range frequency. So.
Okay, great. Any other questions? I could see some from the panel. Someone was saying, can you diagnose like a brain malformation, Dandy Walker and stuff like that? I don't think this is...
Yes, you can.
In the first trimester.
You cannot rule out, but let's say the typical Dandy Walkers are associated with the large posterior fossa. So this can be seen. And there are some questions if images are all vaginal. No, most of the images I showed you were abdominal because, I know that many of you are cardiologists, so you can really, I encourage you to use the transabdominal probe. The question is, will the session be recorded for later view? I don't know. I think yes.
Yes, there is our website, and we have all the fetal series so far. Okay. We have done 6, and they're all there, and you can always.
Can we diagnose the herniated Dandy Walker in first semester? Actually, honestly, what you should know is Dandy Walker is such a rare condition. What you can see is a dilated fluid in the posterior fossa. If you see this, you should think first it could be trisomy 18 because this is the most common condition we see. It can be transient condition. And we will recommend always to rescan, to do a transvaginal scan at 16 weeks to see the development of the vermis.
Great. So one more thing, which I think for the audience, comparing the IceWalk to the Degum that you were talking about, what's the difference in the German, system and the other countries in the scanning?
Thank you for asking this. I did not want to put IceWalk in my talk because it is already old. And if it's recorded, people think it is old. They are now redoing it. and in the ISO work, recommended is only heart activity. The 4-chamber view is optional, and there is nothing but 3 vessels. So what we did here, we said, guys, we want at least, if you want to be good, to have the 4-chamber view, a 3-vessel trachea view in color. This is for us should be. So we put the 3-vessel view as optional and the 4-chamber view as mandatory.
But we usually, as cardiologists, take the outflow tracts. I mean, Lindsay Allen said is 60% with the 4-chamber, 80% with the outflow tract. Now, outflow tract and 3-vessel, it's okay. I mean, there's not a big difference between the two, but still outflow tract is important.
Yeah, but Rima, for me, you are right. But the question is, if you say obligatory means if you have not done this, you missed it. So you encourage people, tell them, please do this as a standard. So I cannot imagine that someone is able to have a proper look to the 4-chamber view with color and 2D and not able to see the 3-vessel trachea view. This one, if you do one, you will do the other one. Now, people ask me often, why don't you do it? It's so simple to switch like this, to have a 5-chamber view, to switch like this, to have a short axis view. Of course, I do it. But if you tell people, it's so simple, do this, do the arza, do the veins, at the end, you have 10 different planes for a simple examination, and this only the heart. The other one comes for the eyes and for the maxilla, the third one for the posterior fossa. At the end, you'll spend 1 hour on doing something simple. People will not do it. What I'm trying to tell people is, tell me any condition where you have an overriding of the aorta, you don't see the 3-vessel trachea view. You have tetralogy, you see the narrow pulmonary artery. You have pulmonary athlesia, you see the reverse flow. You have common trunk, you don't see the V sign because there's interruption of the ductus. You have the right aortic arch, you see the 3-vessel trachea view. So almost all conditions, you see them in the 3-vessel view, and you return back and you can demonstrate the overriding of the aorta. This is my, the only condition is
what you said.
Aortic
stenosis. It's beautiful. This is beautiful. But I mean, what you said about the cardiac axis is beautiful, but you didn't give us the degrees that you said abnormal cardiac axis, because you listed it as 73% sensitivity, right?
Yeah, the paper is written in the Green Journal. You can refer to it. The degree is 45 degrees plus minus, but I did not want to focus on these signs, neither on the tricuspid nor on the cardiac axis. I like them very much, but if you could train people to measure the tricuspid plus the cardiac axis and so on, I think people can now, with the machines we have, go directly to look at the vessels. It's even easier. But the other one is your first impression. So when you have a feeling, does it look good, does not look good, and you put a color and see, oh, looks the heart is almost lying, then you know you should be seeing something in the great vessels abnormality.
Please note that we have 2 schools. We have a fetal cardiology scanning and we have an MFM scanning. So, and we have to unify the goals that saying that, okay, this is what you have to do in the first trimester. And it seems that we have to speak the same language, and internationally people are speaking the same language, more or less. To answer your question, if they don't have time in the anomaly scan or whatever, or to do the heart, it's good to refer it to us. Yeah. Then we can do business.
No, Rima, but if they don't have time, they should not do scan. This is the time is the killer of ultrasound. So you need, my aim is you have to do a checklist and to say normal, suspicious, do you have an alternative, transvaginal, yes, no, or refer to a second opinion.
Thank you so much, Prof. Shawi. And now with the next speaker, we have, I think it's Ulrike Herberg from University of Bonn. And she's a professor and head of the department. Many years back, we used to study together in the same place.
Okay, Rima, thank you so much for your kind invitation. I'm very happy to be here. And I'm also very happy to do these talks together with Christoph Berg. Christoph Berg is a very good friend and we are working together. It's a department of, I'm pediatric cardiologist. Christoph is obstetrician and fetal specialist doing fetal therapy and obstetrician and prenatal medicine in Bonn, the University of Bonn, as well as the University in Cologne. Okay, and now we want to talk about fetal heterotaxy and cardiac and extracardiac findings. So heterotaxy is defined as an abnormal arrangement of the thoracic and abdominal organs. Sorry, it does not work. Yes, across the left to right axis of the body. And heterotaxy, the word is derived from Greek, with hetero meaning different and taxi meaning arrangement. Heterotaxy is caused by the disruption of left-right axis orientation during early embryonic development. And I want to refer to the very first talk of these webinars in January by Professor Silverman, who talked about the genetics and the morphology in heterotaxy. Cardiac and extracardiac malformations are major components of heterotaxy and can be associated with considerable morbidity and mortality. And the incidence is about 0.6% of the cardiac defects detected in utero and about 1.36 of 10,000 live births. There's a recurrence 5 to 10% of siblings, but these are European data, and I think the Asian incidence is higher. Before we are discussing the terminus heterotaxy, we just have to remember the normal body configuration. And in the normal body configuration, the situs solitus, the thoracic and abdominal structures develop asymmetrically and are orientated to the right or left side. So we do have the three-lobed right lung, and the left lung has two lobes. We have a right atrial appendage and the left atrial appendage, stomach, liver, stomach, spleen, and aorta on the left side, and vena cava inferior and liver are on the right side. In heterotaxy, morphological structures that normally develop on only one side are found on both sides of the body. And heterotaxy itself can be stratified into idealized subsets, to make it simple, which have been characterized by the morphology of the atria. So right atrial isomerism is characterized by two right atrial appendages, and left atrial isomerism is characterized by two left atrial appendages.
Ulrika?
Yeah.
Ulrika?
Yes?
Could you kindly, they're saying, could you make it full screen?
It is not full screen. It is full screen on my screen. Sorry about it. Now it's full screen?
I'm not sure. Yeah, now it's full screen.
On my screen, it's full screen.
Okay.
Yeah, now it's full screen. Now.
Okay. So what are the typical findings in right atrial isomerism? So there are bilateral right-sided organs. We have bilateral right bronchi, bilateral right atrial appendages, and this is associated with asplenia. And their situs is an ambiguous situs with the liver in the middle, and the gallbladder and the stomach are variable. And what are the typical cardiac findings? So make it simple. It's not really true, but make it simple to remember this. We have two right atria. So we may have two sinus nodes, and this might be the reason to have rhythm disturbances and tachycardia. And there's also no normal left atrium. So the pulmonary veins have difficulties to find the left atrium. And so in right atrial isomerism, there's a high association with total anomalous pulmonary venous return. And in addition, the atrium septum may be deficient and there may be an absent coronary sinus. What are the typical findings in left atrial isomerism? So we may have bilateral left-sided organs, bilateral left bronchi, bilateral left atrial appendages, and this is associated with polysplenia, and again a situs ambiguous. What are the typical cardiac findings? Now we have bilateral left atria, so there may be a hypoplastic or even absent sinus node, which may be associated with a bradycardia. And we also don't have right atrium. So the systemic veins may have abnormalities. Just make it simple. And pulmonary veins may come into both atria. In heterotaxy, accurate fetal diagnosis is one of the greatest challenges for the echocardiography, and therefore the segmental approach to diagnosis is very essential. Sequential segmental analysis starts with determination of the abdominal situs, so location of the liver, gallbladder, stomach, and spleen, but also, which is the most important, on veno-atrial connections as the leading diagnostic signs. So we have to look for the location of the inferior vena cava and abdominal aorta, and then we do a segmental analysis of the cardiac anatomy. Let's start with left atrial isomerism. In about 93% of all cases, we do find an interruption of the vena cava inferior with azygos continuation. So if we do an abdominal scan, we do see the situs ambiguous, maybe polysplenia, and we also see that the descendant aorta is anterior, and there's no normal caval vein, and there's a dorsal azygos or hemiazygos vein. This is an example of an interruption of the inferior vena cava with azygos continuation in a normal patient. So start the video. This is the azygos. This is the descending aorta. And you do not find, in this case, a normal caval vein. So this vein is below the descending aorta. And as Rabbi Shawi already showed us, if you do a sagittal scan, you may see the azygos vein sagittal below the descending aorta. In right atrial isomerism, the veno-atrial connection may be associated, is associated with juxtaposition of the inferior cava vein in descending aorta. Here, descending aorta in vena cava inferior are on one side, either on the right or on the left side. And again, an example, here the aorta and the vena cava inferior just on the same side in this fetus. So what are the associated cardiac defects? I will show you a busy slide and we make it easier just in the next slide. But at least it's very important that nearly all right isomerism as well as left isomerism are associated with the cardiac defect. And most often these are atrioventricular septal defects. They can be mostly in right isomerism unbalanced AVSDs and in left isomerism balanced AVSD. There may be pulmonary artery obstructions. Red is always right isomerism, green left isomerism, double outlet right ventricle. And now this is important. Total anomalous pulmonary venous return is found in right atrial isomerism quite often and with obstruction. Heart block, and this is AV block 3, so third AV block is complete, is found isolated in left atrial isomerism and may lead to hydrops. So just remember, in right isomerism, there's a high risk of total anomalous pulmonary venous return with obstruction, and in left atrial isomerism, there's a risk of AV block leading to hydrops with a high intrauterine and postnatal mortality. And this is an early scan with a fetus with complete AV block in this fetus, and late scan AV channel, also AVSD with AV block and hydrops. So what are the typical cardiac findings in left atrial isomerism and interrupted IVC, bradycardia, risk of complete heart block? Pulmonary veins will be bilateral to both atria. Postnatally, those patients may be operated and may be able to get a biventricular approach in about 65%. In right isomerism, there's the juxtaposition of the IVC and aorta, risk of tachycardia, high risk of total anomalous pulmonary venous return with obstruction, and also high probability to get univentricular repair postnatally. But there are also, and this is important, extracardiac anomalies, and this is a series of Christoph and from Bonn and Cologne data. And in our cohort, we had about 27% of all patients with extracardiac anomalies, and only 50% of them were detected prenatally, mostly in left isomerism with biliary atresia, bowel atresia, and anal atresia. And the biliary atresia is quite very important to detect this as early as possible. And this is difficult, and repeated failure to identify the gallbladder in the fetus may predict this, but is an unreliable marker. In addition, you may also see malrotation of the bowel, common both in left and right atrial isomerism. So in a short summary, extracardiac malformations in left atrial isomerism are intestinal malrotation, obstruction, and very important biliary atresia. In right atrial isomerism, intestinal malrotation, and asplenia and the risk of infection. So what is the outcome? Left atrial isomerism with a risk of intrauterine bradycardia may have a poor intrauterine outcome due to AV block, but is the so-called beta congenital heart disease with the probability to be biventricular after birth in about 2/3 of all cases, with the 86% 5 years survival and a survival which is variable, but something between 63 to 70% after 16 years. In contrast, right atrial isomerism is the worst congenital heart disease with a complex anatomy, univentricular, and a low long-term survival. So, in summary, counseling in fetal heterotaxy means we have to estimate the outcome dependent on cardiac and extracardiac disease. We have to think about relevant extracardiac disease which may be not detected prenatally. And the classification I just showed maybe is helpful, but we always have to do individual risk stratification based on the segmental cardiac and extracardiac findings. And I want to finish and give Christoph the chance to show his cases with the sentence of Ms. Conan. Heterotaxy syndrome is the Murphy's law of congenital heart disease in that almost anything that can go wrong will. So now, Christoph, go ahead.
Yeah, thank you, Ulrike. It's always an honor for an obstetrician to be invited by pediatric cardiologists. And what I would like to do with you is a little quiz based on some cases that I collected over the years that illustrate rather well what Ulrike and Rabir just told you. And in order to do the quiz, I want you all 200 delegates to open your smartphones and try to make a picture of this QR code. You don't need to make an actual picture. It will open a link to a TET system, and I will show you 5 or 6 cases, and these 5 or 6 cases consist of 20 videos. And at the end, I prepared some questions on those cases, and I'm very keen to see whether you get the diagnosis right.
Chris,
yes.
It's all in German down there, so it says ablehnen, einverstanden. So I think the blue one is, it says yes, so we have to say yes so that people can be able to vote.
Yeah, right. You go to yes. I will just check how many of you. Oh yeah, there are already 30 online, so it works. It works.
Yes, but you have to accept it by saying by saying einverstanden means I agree. so that
Yeah,
you can
right. You have to. It's the University of Bonn is very German based, so that's so yeah.
It's good. It's good. Yeah.
Okay, so let's just start with the first case. And this case begins at 12 weeks of gestation. So left is upwards, right is downwards. So the heart is pointing to the left, which is correct. And then we go down, we can see that the stomach is on the right, and the portal sinus runs to the right too. We don't see any gallbladder. And we have two vessels running behind the four-chamber view. So let's go further. This is a transvaginal scan now from the heart. You can see a central septal deficiency. Now, the left is on the right side of the picture and right is on the left side of the picture. We have levocardia. In the color mode, we can see a centrally located valve insufficiency, AV valve insufficiency, and we can see that the V of the three-vessel trachea view is pointing to the right side instead of the left side. And this is a mid-sagittal view that I always do in cases where the situs is abnormal. And you can see that there is two signals behind the heart. One is the aorta and one is the azygos vein. And you have a reversal of flow in the ductus venosus. So now let's go 10 weeks further. And this is at 22 weeks. Again, you can see the heart is pointing to the left. Here up is the right side. Centrally located septal deficiency. The atria are much bigger than the ventricles. The stomach is on the right side. The portal sinus runs to the right side. The gallbladder is on the right side. So basically everything is on the right side. And we have a double vessel sign behind the heart in the four-chamber view. Let's have a look at the outflow tracts. Again, central septal deficiency. And now let's see at the three-vessel tracheothymus view and on the outflow tracts. We can see that the arterial duct and the aorta run to the right side of the trachea. So the V is pointing to the right side of the trachea. And we can see that there's a supernumerary vessel in the three-vessel tracheothymus view because we have four vessels there. There is one supernumerary vessel on the left side. Again, a central AV valve insufficiency. And in the color mode, we can see the right position of the aorta and of the ductal arch, even better than in the grayscale. And that's about it. Many signs in this fetus, and let's see whether you got your diagnosis right. I will share another screen.
It says here in German, you can choose more than one answer, right?
Yeah, right. Multiple answers may apply. Let me just start with so which of the following answers is true? And you can check as much as you want to. and as many as you want to. So the first answer is the fetus has a left persistent superior vena cava. The second is the fetus has an atrioventricular septal defect. The fetus has a right aortic arch. The fetus has an interrupted inferior vena cava, and the fetus is most likely to have right isomerism. So you can vote on that. I just give you 5 or 6 seconds more, and then I start a countdown. Okay, 5 seconds more. Okay, let's see how the voting is. So most of you have got the answer right. Of course, this fetus has left isomerism and not right isomerism. Indeed, when you look at the cases again, of course, this baby has a atrioventricular septal defect. It has a double vessel sign, so therefore the inferior is interrupted with azygous continuation. This is the azygous vein. It runs cephalad into and drains into the left persistent superior vena cava. And what is very interesting about this case is you all saw that there is a gallbladder that is located on the right side, just beneath the portal sinus, and still this baby died a couple of weeks after birth due to biliary atresia, and that's exactly what Ulrike told everybody, that it is unlikely to have biliary atresia if a gallbladder can be visualized, but unfortunately it doesn't rule out biliary atresia.
And can I make a comment, Christoph? I wonder whether you'd put that picture back up again of
Yes.
that 4-chamber view. Being an Andersonian myself, if you'll just stop that, I think that you can see that there are bilateral left atrial appendages very clearly. And as Bob Anderson has pointed out, that is a really good impression of that gives you the left atrial isomerism. In fact, that's why he named the condition left atrial isomerism. So on the right, you can see what clearly looks like a narrow orifice. You can point that out. And also, if you just go advance through the scan frame by frame, you can see the left atrial appendage. There it is. No, you just passed it. The frame rate is not terribly good. There's the left atrial appendage. So this patient has got bilateral left atrial appendages. You know, the rest of the diagnosis is sort of like icing on the cake. And I just want to point that out for the viewers of this, that that looking at atrial appendage morphology is very, very helpful. I don't think it's the whole truth, because we can't see what is real about the appendage morphology, and that's the pectinate musculature. But certainly in left atrial isomerism, shape is useful. In right atrial isomerism, you can almost always see the terminal crest, or the crista terminalis. And if you see bilateral terminal crests, you've got a right atrial isomerism. So I think that it's very interesting, all of these findings, to show this, but there really is bilateral left atrial isomerism in this patient.
Absolutely. And 10 years ago, we did a retrospective study looking at all those atrial appendages. And in the retrospective setup, it worked very well. Now, then we followed this way prospectively. And what I experienced is that if the cardiac anatomy in right isomerism is really, really troubled with a singular ventricle or with multiple associated cardiac anomalies, then it gets really difficult to determine the shape of the atria. It's much easier in left isomerism because the cardiac anatomy is not so distorted as in right isomerism.
Well, I mean, I think that looking at the pectinate muscles is difficult, but the terminal crest is relatively easy. And even here in left atrial isomerism, if you can go back to that picture, although the appendages are isomeric in terms of their shape, they're not in terms of their size. And probably that relates as well to the issue that is occurring in the physiology of this condition, that is greater hemodynamic burden on the right side of this atrium than on the left side.
Absolutely.
Dr. Silverman, is the axis here, is it the right axis or a mesocardia?
Well, it's more mesocardia, but it's definitely not a right axis.
Yeah.
Now let's have a look at the next case. This case starts at 17 weeks. We have left is left and right is right. The stomach is on the left side, the portal sinus runs to the left side, and the gallbladder is on the left side. So this could be a persistent right umbilical vein, but in this case, it is situs ambiguus. This is matched by the cardiac findings where you can see the centrally located septal deficiency, again, like in the last case. And in the color Doppler interrogation, again, we have a very slight centrally located AV valve insufficiency. The V of the 3-vessel tracheothymus view now runs to the left side, which is normal. And again, we look at the mid-sagittal view and you don't see the inferior vena cava that should be around here, but instead you can see 2 vessels running behind the heart, the double vessel sign. Now, let's go a couple of weeks further. That's 28 weeks. We got the same findings. The stomach is on the left side. The portal sinus runs to the left. The gallbladder is on the left side. But what you also can see is that you have dilated bowel loops nearly everywhere in the abdomen, and that's much too early for the bowel to look like that. If we look at the heart, you see again what Norman Silverman just told us, the finger-like shape of both atrial appendages. We got the centrally located septal insufficiency and a supernumerary vessel on the left side in the 3-vessel tracheothymus view. Nicely depicted here also the double sign in the 4-chamber view. The color Doppler interrogation reveals basically the same. Here again, the left persistent superior vena cava, which is not universally seen in heterotaxy syndromes, but in 60% of those. And now let's go a couple of weeks further even. That's 32 weeks. Now we have heavily dilated bowel loops. We got a massive polyhydramnios, and the baby is born a week after this video has been taken because the mother went into preterm labor. Now let's go to the questions again. I hope this will work. Next question. So, which of the answers is true? The fetus has an atrioventricular septal defect. The fetus has left persistent superior vena cava. The fetus has small bowel atresia, most likely due to lead bands. The fetus has juxtaposition of the aorta inferior, and the fetus most likely has left isomerism. So I give you a hint, there is one answer that is wrong. And actually nobody can see how you vote. This is absolutely anomalously. So you can be absolutely free to vote as you like. So I'm starting the countdown, and we will see how you decided. 5 more seconds. Yeah, everybody has got it right. This baby hasn't have juxtaposition of the aorta and the vena cava inferior because it had an interruption of the vena cava inferior. The other possibility would have meant that the baby has right isomerism instead of left. So let's go further. This case also begins in early pregnancy at 13 weeks, and you can see that this baby has a spacesuit phenomenon. It's a generalized hydrops, and Rabia Chaui just showed you a similar case a couple of minutes ago. Already in the first trimester, you can see the centrally located septal insufficiency. Let's go back here. The heart, the cardiac axis points to the right. The stomach is on the left side. The portal sinus points to the left side. And again, it's hard to see the gallbladder, but that's pretty frequent in the first trimester. You can see that the cardiac rhythm is disturbed. We have a ventricular frequency of about 60. Again, we have two superior vena cava. In the mid-sagittal view, we have a double vessel sign. The vena cava inferior is missing. It should be here. And if you put the sample volume of the pulse wave Doppler in the azygous vein and simultaneously in the descending aorta, you can see this heart rhythm. On the lower side of the scale, you have the atrial frequency depicted in the azygous vein, atrial, 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 the A waves, and then you have the ventricular beats in the upper part that basically have a 2-to-1 conduction. Now let's go to the questions again. So, which of the following answers is true? The fetus has an interrupted inferior vena cava. The fetus has an atrioventricular septal defect. The fetus most likely has left isomerism. The prognosis of this clinical picture is almost invariably fatal, and the fetus has an incomplete AV block. Okay, we are a little bit behind the time, therefore I will start the countdown right away. Of course, all of these answers have been correct. The prognosis of this clinical picture is almost invariably fatal. And there is no other reason for a first trimester AV block than the left isomerism, because the antibodies that may produce an antibody-related AV block, the anti-Rho antibodies, they do not cross the placenta until 16 weeks.
So would you call that 2-to-1 AV block on that beautiful picture you showed? Because it seems that there's post-ectopic potentiation of the beat. When there's a long pause, there's a greater cardiac output exactly after the long pause. But if you look at the atrial contractions, they're almost entirely asynchronous with what? So that this looks like a ventricular mediated conduction for ventricular function. Yeah.
You know what is funny is that in the last 10 years, I saw 5 first trimester AV blocks. They were, of course, all left isomerism, but they were extremely hard to, how do you say, those rhythm disturbances are not like in the later pregnancy periods, and this asynchronized atrial rhythm is in all of the 5 cases that I saw. How I would read this is an atrial contraction that is followed by a ventricular contraction. This also is followed by one, and this one is blocked.
Yeah.
But if you continue to do this, you will see that it doesn't work.
Right.
And those very early AV blocks or incomplete blocks are really are hard to read.
Sure. You know, there's one other issue here. I mean, I've described this. Mark Friedberg and I call it the Friedberg-Silverman syndrome, but nobody else has actually recognized this as a syndrome. So I'm kind of trying to popularize the Friedberg-Silverman syndrome, and that's the association of left isomerism with spongy myocardium. And I think that when you look, if you go back on that first picture you showed with the ventricle, the ventricles have got a particular kind of peculiar, there we go, ground glass appearance to them, like people describe in hypertrophic cardiomyopathy. And I think that the reason that this is probably also a feature of left isomerism is the spongy myocardium. And of course, when you consider the whammies, as we call them in America, this is a triple whammy because there's isomerism with AV canal, which doesn't function that well. There is a heart block, and there's also a myocardial element related to the spongy myocardium. I think that's a spectacular picture that you've shown there. And it doesn't look like we see in a child who's larger, because you can't get into those small interstices of the spongy myocardium, and it gives that funny ground glass appearance, like you know, they put on office buildings so that you can't see in the offices. And I think that's a fairly typical feature. Did this patient indeed have spongy myocardium on autopsy? And did the fetus die in utero?
Absolutely, yeah. They actually, it is just one of those 5 cases continued into second trimester. Mm-hmm. These cases all died spontaneously, mm-hmm. Intrauterine, so they were not aborted iatrogenically. So therefore, they never had a proper pathology examination, which is a very, I don't know whether it's an international problem too, but it's a German problem. We basically don't have any fetal pathologists anymore. This is just very badly paid, and it's the universities are not really interested in this topic. So basically, there was a very good one at the Charité with Rabi El-Shawi, Cornelia Tenstedt, but she does something something else now, and so we are left with just one fetal pathologist in the whole country. That is in Marburg.
Yeah.
It is really a very, very bad situation. So we never get a pathology in our cases, especially not in cardiac ones.
Sure. I've published a series of those a couple of years back, and we had a gentleman who's also retired now who was very interested in cardiac pathology and including histology. So we have low microscopy to show these spongy myocardiums in these fetuses as well. But I think that, you know, the echo is pretty much, I think, important in looking at this, and that this spongy myocardium, especially when you see it in the fetus, is really a cardiomyopathy, and the function, even though it looks like the heart is able to generate pressure, this together with the heart block is just too much. And if there's AV valve insufficiency related to the AV septal defect, then of course you have the triple whammy, and I've never seen a fetus survive with this. I should say I had one patient that was delivered, but the fetus never breathed. So the fetus was essentially born dead with this condition. And it's a beautiful example, Christoph. Thank you so much for showing that. Let me just ask the panelists while I have everybody here, before I shut up, is that in my experience, left isomerism in utero is a much more difficult and serious condition in terms of survival. And I believe it's this because of all of these issues. So right isomerism, which is a much worse disease, I'm sure everybody would agree with that, is better handled in utero than left isomerism. And the fetal loss with left isomerism is probably all related to what you've just shown us over here. Would you agree? If you can expand on that, Christoph and Ulrike?
Yes, we agree. Yes, Christoph.
No, we had, and I just wanted to say that we had, together with Ulrich Gembruch, we had 165 cases in the last 15 years. And it's absolutely true that left isomerism has the biggest loss rate during the prenatal phase, and right isomerism has the greatest loss rate in the first year of life.
Mm-hmm. Yeah, and then they continue to do it after that. And I think that's certainly for the obstetrical reviewers of this session is, you know, after the baby's born, it sort of doesn't, it's not your problem anymore. And it's our problem as pediatric cardiologists, and the loss of patients with right isomerism continues to be bad. In Toronto, they published a series in 2000, which is already 20 years ago, that they said patients that had the need for surgery to correct a total anomalous pulmonary venous return in the right isomerism were all dead at 5 years of age. And they've been following their isomerism population for for 30, 40 years already. And so that's their experience. I think maybe now they will save a couple of those, but that's certainly a very poor prognostic feature when you see obstructed veins in right isomerism in the fetus.
Yeah, that's a perfect prelude to the next cases. This case begins at 25 weeks. On the right side is right of, and the left side is left. We have a stomach on the right side. We have the portal sinus running to the left. We have a gallbladder, a rather large one, also on the left side. So this is clearly cetus ambiguous. We have an unbalanced ventricular architecture. This common AV valve just opens preferably for the right ventricle. We got just one single vessel exiting the heart, and it bifurcates very close to the trachea. So this must be the aorta. We got the central AV valve deficiency. Here we can see the pulmonary artery that is perfused retrogradely by the ductal arch. Therefore, we have a red signal here. We got two vena cava superior in the 3-vessel tracheothymus view. And we got what we saw in the abdominal scan is that we indeed have an inferior vena cava running on the same side of the spine than the aorta, so that's juxtaposition. So we already have a suspicion that this might be right isomerism. And once you have this suspicion that the fetus might have right isomerism, you have to explicitly look for pulmonary venous, anomalous pulmonary venous drainage. And if you do this in this case, you will notice that if you look at the left superior vena cava, you will have a jet here, a blue jet, and you need to notice this blue jet, because this is the killer for the baby. Just as Norman said, they rarely survive, and this baby also didn't survive. It died at half a year of age. So this jet tells you that this baby indeed has a totally anomalous pulmonary venous drainage of the supracardiac type. And it's really hard to see it if you don't notice it in the color mode in the vena cava superior, because this to notice the horizontal vein here in the grayscale picture in the 4-chamber view is really not easy. Actually, I think you just see it if you know that there must be a totally anomalous pulmonary venous drainage. And it's not really easy to see that those pulmonary veins are not connecting to the atria. So it's essential that you recognize this flow pattern, because then you notice that the pulmonary veins are confluing here and then running cephalad in direction of the superior vena cava, of the left persisting superior vena cava. And at the insertion side, at the drainage side of the inferior vena cava, you have a marked obstruction, and this tells you that the chances of this baby are really, really limited. I will not go to the poll again because we are way out of time. I just show you another and a last example before we go back to Ulrike. This is a fetus at 25 weeks. Left is right and right is left. So what we can see is that the heart is pointing to the left. The gallbladder is on the right side. The portal sinus is running to both sides. So it's really hard to tell whether it's a right or left portal sinus. And we got many, many, many vessels running behind the heart. We got 1, 2, 3 vessels running behind the heart or near the spine. And it's not easy to determine that in the grayscale picture, but this here is the aorta. Then we have the vena cava inferior running here. juxtaposed on the same side of the spine. And this here is the drainage side of the pulmonary veins. Of course, we have an unbalanced atrioventricular septal defect, and we have a transposition of the great arteries. If we, here you can see the transposition, and if we look at the pulmonary veins, it seems that they are entering the right atrium, which would exclude a totally anomalous pulmonary venous range. But if you do the mid-sagittal view, you can see that they are just entering the vertical, the horizontal vein behind the heart, and then they take a downward course, and this is a massive vessel that runs into the liver veins that can be nicely depicted in the 3D reconstruction. Here, the red vessel is the drainage of the pulmonary veins into the liver, and this baby also didn't survive the first year of life. So that's all from my side. Thank you very much for your attention.
Thank
Sorry,
you, Chris.
just
You took
before
us.
we go, Rima, may I just make a comment?
Sure.
Christoph, I think you showed something very important, and that is what we've described as the twig sign. When you look at the fact you see the back of the left atrium is bald, I wonder whether you could maybe just put your pictures up again. Sure. Because both of the right isomerisms that you showed had anomalous pulmonary venous return, and the back part of the one, 2 or 3 before that one, you can see the descending aorta is really in front of the spine, and there's a great deal of distance between the left atrium, the left-sided atrium, and that little twig of tissue that is the pulmonary venous confluence, or some of the pulmonary veins coming together. And that's there you are. You can see, I think that even with black and white imaging, you can really see that this is a venous structure which does not make contact with the back of the atrium at all. And so I think on black and white imaging, and then when you add the color to it as well, you see that, and as you go down, you can actually see that vein descending down towards the porta hepatis. So I think that's a very important sign as well for right isomerism. The other thing I didn't notice on that picture, if you can just put it up again, is do we see any terminal crests in that ventricle? When you get to see the atrial appendages, they're isomeric, they're big, and I don't know that you concentrated on that area, but you see that little white dot there, just at the origin of the atrial appendage is the terminal crest. And those look like bilateral right atrial appendages to me.
Thank you. I think this is very important, Dr. Silverman, regarding the pulmonary venous connections in isomerism. Now, by default, if you have right atrial isomerism, i.e. you have 2 right atria, do we have to have anomalous venous connections? I know the answer is no, that's not 100%, and why is it?
Are you asking a question?
Yes, I'm asking you. When in right
from?
atrial isomerism, by default, we should have a total anomalous venous connections and normality.
I think what Rima is referring to is the clash of the giants between Van Praag and Bob Anderson. Whether isomerism is really isomerism, or whether it's a misnomer.
Well, I mean, I think it's difficult for other people to get into this because each one of them has got their point of view. And we know, I think the answer to Rima's question, it relates to those great papers in cardiovascular imaging from the group in Toronto, where they talk about violation of this. You know, genetics is not perfect. Not every genetic thing is exactly the same as every other genetic thing. And certainly it's clear that, you know, you can have the features of isomeric atrial appendages that would tell you you've got right atrial appendages and there are multiple spleens. Or you can have left atrial appendages and 2 right-sided bronchi. And this occurs in about 20% of all isomeric cases, according to the people in Toronto. And in fact, in Anderson's series a little while before that, he found the same problem. So we don't know what is the primary thing. I think that atrial isomerism, I might get killed if I say this being an Andersonian, is that what we need to talk about is double right-sidedness and double left-sidedness in terms of patterns. And we don't really know what the pattern is, but certainly with, you look at this postnatally with magnetic resonance imaging, there are certainly a number of patients where not everything is perfect in isomerism. And we know in genetics, not everything is exactly perfect. You can have a trisomy, which like a Down syndrome, for example, and the levels of intelligence in the 2 subjects may be entirely different. So there are many multiple factors that go into making genetic abnormalities, and we don't know what the real fundamental is yet, and whether it's a whole concerto of genes that are acting together then have to act in the right way. And if one of the players is playing incorrectly, then you get all kinds of other anomalies.
So basically a learning point that in right atrium isomerism or left atrium, right atrium isomerisms, you will not always get anomalous pulmonary venous connections. You can have normal.
That is correct.
And in left atrial, in left atrial isomerism, you will not always have heart block, despite the fact that we don't have a right atrium.
That is right.
Yeah.
But, and the thing about heart block, I think that we have to remember, and for the obstetrical people in this group, is that we know that the heart block is not necessarily initiated in utero, and that there is an ongoing issue of heart block after the patients are born. So, and even up until adolescence and adulthood, you can get the development of heart block. And so not everything is clear about conducting tissue in these conditions. And certainly you can't use heart block as a be-all and end-all of the diagnosis of isomerism, or as I like to call it, double left-sidedness.
Thank you so much. And I'm not sure if we have, have time. Rika, you wanted to say something?
No, it's up to you. Mm.
No, Dr. Silverman and Dr. Shawi and all the rest. Can Ulrika give us like a 10 minutes talk, and then we will conclude?
Absolutely.
Yeah.
I'm sorry if I went on a little bit. I thought we were over with everybody's presentations.
No, but it's fine. If you want, so we can go on and talk about pulmonary venous return. Do you see the full screen?
Yeah.
Yes.
So just make it short. In the context of heterotaxia, we already talked about total anomalous pulmonary venous return. And I now want to talk about the more or less isolated situation of total anomalous pulmonary venous return. And we know that it represents a rare anomaly, and it's quite often overseen prenatally. It's difficult to diagnose. And the etiology of total anomalous pulmonary venous return is the failure of the pulmonary veins to establish drainage to the left atrium. And as a consequence, there is a vertical vein or an abnormal connection to the systemic veins. And finally, then to the right atrium. And this disease can be categorized in 4 main groups, depending on the connection of the vertical vein to the systemic veins. So these are the supracardiac form. So the vertical vein drains into the upper abdomen. It's the most often seen form. The inferior form, the vertical vein drains to the lower part of the body. The intracardiac form, which represents about 25%, draining into the coronary sinus or isolated into the right atrium, and most rarely the mixed form. Now, this is a quite interesting case, and I try my best. I have to move this a little bit. Okay, so this is a case, and you see here the 4-chamber view. And now we want to identify in this case if this is a normal 4-chamber view. So we do see right atrium, right ventricle, left atrium, left ventricle, and we should also look for the pulmonary veins. And it's quite difficult in this case to see clearly pulmonary veins entering this left atrium. And there's also this funny area here and here. And if we see the 3-vessel view, we also see a dilated vein somewhere here. So if we continue, there might be a little bit larger right ventricle, but it's a larger right atrium. So the left atrium is smaller. And we are not sure if the pulmonary vein really clearly are connected to the left atrium. So what are we doing? Next step is to put on color Doppler. And this is a normal heart. And we use low PRF, a small color box, to identify the pulmonary veins and see if the pulmonary veins are draining into the left atrium. In this case, in this normal case, they do. Now we're coming back to our case. And again, it's quite difficult to see and to recognize if there are pulmonary veins connecting to the atrium. And we are also able to see that there is, in the 4-chamber view, there's one space here, which is then without flow. And later on, if we go more cranial, we do see behind the pulmonary artery some higher velocity flow, and also the brachial vein was larger. So if we are not sure if the pulmonary veins are clearly connected to the left atrium, we should always use color. In addition, we have to look at the space behind the left atrium. And this is a wonderful picture of Rabbi Shawi showing the normal heart. In the normal heart, the left atrium is relatively close to the aorta. So the space behind the left atrium is small. And there are not additional structures behind the left atrium. But in this case, in total anomalous pulmonary venous return, we do see that there is something else behind the heart. The confluence, or as I learned, the twig sign. And there's also an increased space between the left atrium and the aorta. And this is again showing a figure showing the confluence here and the increased retroatrial distance to the aorta. In total anomalous pulmonary venous return, now we are going back to our case, and we do see a very small confluence and this large space between aorta and left atrium. So in this case, we thought of pulmonary venous drainage via a vertical vein into the upper body. And typically, in these cases, there can be a connection to the brachiocephalic vein, to the SVC, and only in about 45% of cases, there are obstructions. If we go to our case, and if we look for the 3-vessel view, as I did here, the cut, we are able to see the vena cava superior, or here in this cross section as well. We can see the aorta. We can see the pulmonary artery in the front, and backwards, we are able to see the 4th vessel, which should not be here. And this is the common pulmonary vein or vertical vein. And if we advance our ultrasound transducer further cranially, we do see also this large brachiocephalic vein, and the vertical vein is then running into the brachiocephalic vein. So in our case, we think this is a supracardiac form of total anomalous pulmonary venous return, but one thing is missing. We saw this high velocity here, and now we have to look for the Doppler measurement and look for an obstruction, as in this case, we see a very, very high continuous flow with a very high velocity. So this is a severe obstruction in this vertical vein. So what are the red flags for supracardiac total anomalous pulmonary venous return? Pulmonary venous were not clearly connected. We had the typical signs of posterior venous confluence, increased retroatrial distance here, presence of a vertical vein here, extra vessel in 3-vessel view, and dilated brachiocephalic vein. And in contrast to a true LSVC, so if this would be the 4th vessel, and if you think of LSVC, the LSVC will be more anteriorly, and always the brachiocephalic vein is smaller if you have a true LSVC. What are the red flags for infracardiac types? So in infracardiac types, the confluent drains inferior to the diaphragma, most often to the portal veins. There's very, very often an obstruction, so high risk postnatally for the neonate, for a pulmonary edema. And we look for extra vessel in the thorax and abdomen. And here is again a typical case. And you are able to see here this extra vessel, which goes up to the portal vein sinus here. Goes up to the portal vein sizes. Okay. So finally, red flags for the intracardiac type, and most often these are drainage in the coronary sinus or in the right atrium. There's a dilated coronary sinus without a LSVC. So in summary, take-home message, when do we have to look for total anomalous pulmonary venous return and how to diagnose this? Follow the simple rules. Is there a connection of the pulmonary veins to the left atrium? You always have to look for this in every normal heart. Use small color box, use low PRF. And if you are not sure, look for a vascular confluence behind the left atrium, space behind the left atrium. Look for a vertical vein, either an extra vessel in the 3-vessel view or abdomen. Look for dilatation of the coronary sinus or dilated brachiocephalic vein. Exclude if you think this is a total anomalous pulmonary venous return obstruction, because this is a postnatal emergency. You have to deliver these cases in a center with the opportunity to operate or do a cath directly after birth. Always check if there's an association with heterotaxy. We learned about this. And on counseling, you always have to counsel, especially if there's obstruction, for recurrence of pulmonary venous obstruction in 1 to 10%, and also pulmonary hypertension. So thank you for your attention.
Thank you, Rika. Beautiful, short, and to the point as usual. I'd like to open the floor for 5 minutes discussion. And Dr. Silverman, do you have any comments?
Norman, you have to unmute yourself.
A lot of people would like me to remain muted, but I think that the most important point for everybody here is that I gave a talk similar to Ulrika's at a conference, and I was the last speaker, and so I got to see everybody else's slides showing all different kinds of cardiac pathology. And in every one of them, on every one of the slides that they showed, there was connection between the left atrium and the pulmonary veins. And that's one of the easiest things which we can do. And yet the anomalies of pulmonary veins are one of the most frequently missed diagnoses, especially in my area, maybe not in Germany. But I think that for the people listening, the most important thing is always look to see that the pulmonary veins are draining to the atrium. And you don't have to see all of them to exclude total anomalous pulmonary venous return. one or two veins that you see draining to the left atrium exclude total anomalous pulmonary venous return. And the problem with total anomalous pulmonary venous return is the point that you've made, that the veins can be obstructed. And we know that almost all veins that drain below the diaphragm are obstructed, but only a proportion of the veins that drain above are obstructed. And the veins that are obstructed go in what we call the hemodynamic vice. And that's that the vertical vein that runs up, whatever its structure is, runs between the pulmonary arteries and the bronchus, the tracheobronchial tree. And it's that compression that causes the obstruction in the pulmonary vein. And a lot of them, the pulmonary vein runs anterior to the pulmonary artery. And I think that that's one of the areas that we should focus on in future, to see where is the anomalous pulmonary vein in respect to the pulmonary artery, because certainly this is the last major disease which is a cardiac emergency, a surgical emergency. You know, we've got prostaglandins, we've got indomethacin and other things that we can open and close the duct. And so most of the other circulations can be managed, and we can open the atrial septum in transposition. But in total veins, there's nothing you can do. When it's obstructed, the patient is on a downward course, and the longer you take to do that surgically after the patient's born, the greater the morbidity for that patient, including death. So as fetal echocardiographers or fetal sonographers, should I say, because not everybody's a cardiologist, the most important thing that you can do is define whether there is the presence of obstruction or not. And patients with obstruction have been taken now from fetal cardiac diagnosis directly to the operating room, not to waste time and allow an operation before substantial obstruction occurs. Because although it may be bad in utero, when the placenta is lost, the total cardiac output has got to go through the pulmonary veins, and it gets much, much worse. So I think as fetal echocardiographers or sonographers, we need to be able to recognize on the vertical vein that drains above, whether it's anterior to the pulmonary trunk, the pulmonary artery, the left pulmonary artery, or posterior. And I think that's certainly something that we need to look at in the future.
Dr. Silverman, thank you so much. So if you want to choose to have a baby with left or right, we choose to have the left, right? Take home message. The left isomerism is better postnatal outcome than the right.
I would choose situs solitus if I'm going to make a choice.
Yeah, and then
I don't want either of those conditions.
But out of the two, as Dr. Berg kindly showed, that the postnatal outcome of left atrial is better than the right, yet in utero death is mostly more with the left atrial isomerism. I would add what you kindly said, and what we wrote a paper together, if you recall, that in left atrial isomerism, probably the rate of the spongy myocardium is higher, and then this will cause more of the fetal deaths. Do you agree to that?
Yes, I do. If we wrote it together, I must agree.
No, that was many years back. But also what Ulrike said, the counseling. Now, as cardiologists, we have to counsel the parents. What are you going to tell the parents?
In which case?
Which case?
Is there a recurrence risk? Dr. Silverman, is there a recurrence risk?
Is there a what?
A recurrence risk.
No, I don't have a return switch.
And so the question is that, is there a recurrence risk with isomerism? Maybe Ulrike, you mentioned 10%.
Yeah, 5 to 10% of literature.
Yeah.
Yes, there is recurrence risk.
Yeah, 5 to 10%. I can tell you.
Oh, I'm sorry, I didn't hear what.
Yeah, outside the chromosomal issues, right?
No, look, Rima, in the meantime, we know that, 10-20% of all isomerism may be due to PCD, primary ciliary dyskinesia.
Yes.
And some of these, this is part of ciliopathy, may have 1 to 4 recurrence risk, especially in your place because you have consanguinity. I see a lot of in Arabs, so this can be due to ciliopathy, one of the PCD, like what we called in the past Ivermark or Cartagena. So, and we may have seen, if you remember well, you may have one child with the situs inversus and the next one having left isomerism. So it's, the inheritance is not 1-to-1 always. So.
Well, I think that the genetics of that is becoming increasingly interesting because there are unicilial organisms in the primitive pit area of the embryo during gastrulation, and that the cells that pass through this are seeing a waving cilia or no waving cilia. And the waving cilia are on the right side, pushing the cells over to the left. So that, you know, I mean, and this is so fascinating to understand because when the cells go to the left, that says that they are going to be left-sided cells. And if they don't go, they're right-sided cells. So if you have no cilia, then you probably get a higher incidence of right isomerism. And if you have cilia, then you get an incidence of left isomerism. And there are genes that are involved in cilial motion, including NKX2.5 and a number of other organs. And there are genetic issues in isomerism, such as the ZIC3, which is a sex-linked recessive. But the Cartaginous syndrome, the so-called primary ciliary dyskinesia, there are now about a dozen genes that are reflected in cilial motion in all kinds of organs like the nasopharynx and the bronchi and the sperm, etc., etc. So there are a number of genetic things that related to that. And if the cilia are a problem, then the cells don't move in the right direction. And that's how you land up with these isomeric issues. So I think that in the future, geneticists are going to be able to tell us more about this condition than we currently know.
Rima, can I show you, can I share my screen for a second?
Sure, I think it's an important point.
This is a paper in circulation by Pierpont on the 2018, and many things are written there. And if you look at this part, where I will find somewhere like this here, and there is a special paragraph on PCD and on heterotaxy and wait, sorry, give me a second. 675 here. Heterotaxy and ciliopathy. They discuss the issue of cilia and heart development, and they separate between the paramycelial dyskinesia and also the role of cilia in these things. So it's available, and it's written also in heterotaxy specifically. So it's really worth to read. And
just show us the front part of that, the top part there, so we can get the reference.
Yeah, excuse me, sorry.
Just show us the
yeah, exactly. Give me a second. Sorry. This was the here.
Thank you. Okay.
It is published in Circulation 2018, November 18.
Yeah. It's very interesting. So everything goes back to the cilia. How nice.
Now the heterotaxy group is known. Yeah.
There's a whole lot of different genes involved. I mean, the problem, and that's the problem, is that there's so many different things that are involved that, you know, it's not just a simple thing like one of Gregor Mendel's P genes. There are a lot more genes involved. And even Gregor Mendel, you know, it's interesting, all of the 7 characteristics that he described existed on 7 different chromosomes. He only chose one thing from each chromosome when he did this. And genetics is so complicated. I mean, it's just quite beyond clinicians like me to get to understand this. And the geneticists have not made it easy for us to understand exactly the complexity of their work.
But at least the message will be to always think of genetics when we're counseling. But let me make one note that we are talking about non-syndromic heterotaxia, correct?
What syndrome?
Non-syndromic. just
Yes.
heterotaxia without syndromes. So
Sure.
the recurrence risk, the counseling, we're not including any syndromes here.
Mhm.
Mm.
That's true.
Right.
There's a number of them that we
Thank you
haven't
very
been
much.
able to discover the genetics.
Yeah, well, thank you. Thank you. Thank you, Dr. Silverman, Dr. Shawi, Dr. Herbert, and Dr. Berg, and all our audience. And too many thanks to our audience who've been staying with us for 2 hours. I just want to say that the whole webinar will be online. You can watch it at your leisure time on YouTube. And don't forget to put likes on the YouTube. And the next session is going to be all in Italian. So we're going to visit the Italian group talking about counseling and also congenital heart disease in Italy. And it's going to be last week of next month. So please register as soon as you can. Thank you again.
Thank you. And the German examples were absolutely fabulous. Thank you very much for all of your wonderful work this morning.
Thank you, Rima. Thank you, Norman.
Thank you.
Thanks,
Thank
you
you.
guys.
Rima.
It was a
Thank you,
nice
Dr. Shawi,
session,
for
and
coming.
thank you for being part of it. Because it was
Thank you.
Germany, we say in German, Auf Wiedersehen.
Cheers, cheers.
Auf Wiedersehen. Tschüss.
Well, we say it informal, cheers. So people will
Cheers,
say
yes,
like,
yeah.
yeah. Okay.
Yeah.
Thank you.
Yeah.
Thank you.
Bye.
Bye.